is Natasha Michael. I'm a consultant in palliative medicine and director of palliative medicine at Cabrini Health, and I also hold an honorary adjunct clinical associate professor appointment at the University of Monash. So I suppose when we think of how we care for people with a life-limiting illness as they approach the end of their lives, it's important to remember some basic principles or first concepts, and importantly to embed these principles in how you care for the patient throughout their trajectory. And within the Catholic context, we remember and we uphold a culture of life, a culture of healing, and very importantly, a culture of meaning as well, that you allow people to try and find meaning or purpose even as they approach the end of their life. So death is seen as a natural progression of life. It's a natural part of life, and it's something that we accept, and it's something that we embrace in the continuum of care that we provide to patients. So I'm a palliative care physician, so a lot of the work that I do is caring for people who will reach the end of their lives. And there is a paradox, because when people think of palliative care or end-of-life issues, they think of death and dying. But actually what you're trying to achieve is to enhance life and living until somebody gets to the point of death. So you live until you die. You encompass and you embrace the concept of living, and even as people get weaker or sicker, you allow and facilitate any adaptations to their quality of care or their living standards or their capacity to be mobile, etc., to enable living up to the point of death. So it's almost a paradox. You can even say it's a tension of the opposites. You're talking about death and dying, and yet you're trying to promote and encourage life and living. When we look at end-of-life care, or particularly in healthcare contexts, there's a danger that the view can be very unidimensional or very biomedical. But when you look at people in terms of their whole personhood or their humanity, then you have to look at the different components of that personhood. So there is the physical component, the existential component, the spiritual component, the social component, the biopsychological component. And you need to care for and ensure that all aspects of that personhood gets equal and necessary attention. So a good practical example is when we manage pain in somebody at the end of life. One approach would be just to give them simple analgesia, but the answer to analgesia is not always analgesics themselves. Yeah? So to remember that the concept of total pain means that the person might be having spiritual pain, existential pain, social pain, the pain of leaving a family member behind, the pain of unfinished legacies or lack of forgiveness or pain of hurts in the past. And when you address all of the different components of that person's pain, including their physical pain, then you provide whole patient care or whole person care, and you provide a multifaceted approach to care, caring for the whole person in its entirety. So the unit of care in the Christian context, the Catholic context, would be the patient and their family. We recognize that people are not individual beings, that we recognize the concept of relational identity, that what forms us as people or human beings within our individual lives, family lives, or societal lives are the connections that we have with each other, and connections within our own family unit and external to our family unit. And when you provide care, that you have to be attentive to all of these different groups of people that you care for, the caregiver, the children, the grandchildren, the parents, the neighbors. If people come from societies, the community of care, so setting up bereavement support programs, working with schools, working with groups of communities that live together, that worship together, providing support and guidance, particularly for end-of-life care issues that might be difficult. If you have young people at the end of their life with children, providing supports to schools. If you have people dying in residential aged care, other residents mourn the loss as well. So how do we recognize that collectivism, the fact that we live in not in individualisms, societies of individualistic beings, but how do we recognize collectivism, and also how do we promote and recognize relational identity? Yes, so I suppose when people get to the end of life, these are very common issues that arise, both for the clinician, the patient, and for their families, as to when should you initiate treatment, when should you withhold treatment, and when should you potentially even withdraw treatment. And there are many ways in which one can approach these things. From an ethical perspective, you might want to consider whether the treatment is considered an ordinary means, when it's considered morally acceptable and maybe even mandatory that this treatment is given to promote life-sustaining effects for the patient, and it's considered acceptable and non-burdensome to the treatment, for the patient, I beg your pardon, versus what's considered extraordinary means, where we are recognizing that we are dealing with somebody that's approaching the end of life, and actually initiating or continuing a treatment might actually cause harm or might be overtly burdensome to the patient from a variety of different reasons, from practical reasons, existential reasons, social reasons. So a very simple example of that might be the use of artificial feeding or tube feeding. So one of the common ethical debates that arise is, should we feed somebody with advanced dementia? So in that context, you need to consider what is the end point of this patient's illness is. So from a clinical perspective, we understand that dementia is a life-limiting illness, and really in many patients with advanced illness, we want to take a palliative approach to care. We understand also that the insertion of a nasogastric tube in these patients can potentially cause harm, because the patients might tug at it or pull at it. There's a significant risk of aspirating of the food going into the lungs. We know that from the scientific literature. We also know from evidence that we've collated that actually does not prolong life. In many ways, it can actually cause more detrimental effects to patients. So that can be considered an extraordinary means where the benefit of harm outweighs the benefit of good. And we recognize that we are going to allow for comfort care. We treat symptoms as they arise, we preserve the dignity of the patient, and we allow for the natural course of the illness to proceed. The other side of that argument might be somebody who's had a large stroke. And when people have strokes in the initial phases, it's very difficult to know whether they're going to recover from it or whether death is going to be the outcome. And after a period of acute observation, and the patient then stabilizes maybe to a highly dependent state, sometimes even a state where they might have periods of wakefulness or sleepfulness, it might be then appropriate to consider feeding. And in this instance, we have significant evidence that sometimes good nutrition promotes improved well-being and recovery. So it might not be an extraordinary means in somebody where they're not agitated and likely to pull their tube out or cause discomfort or harm to them. And particularly if it's going to promote the recovery of the patient and appropriate preservation of life, in those instances, feeding might be appropriate. So withdrawing treatment can be sometimes more challenging than initiating treatment. So it's when we are starting to clearly see a course of trajectory in a patient where we actually no longer seeing the benefit of the treatment, and potentially might even be seeing the harmful effect of the treatment. For example, somebody who's on dialysis, who's been on dialysis for many years, when their fistulas might start to break down, or they are starting to get numerous complications from the process of dialysis, or they are aging naturally, and the effort of getting to treatment regularly on every second day basis or third day basis might become overtly burdensome for the patient, and they then have appropriate conversations with their clinicians about potentially withdrawing such interventions. And in this instance, dialysis is an artificial means of preserving life. It's recognized that the patient has had a clear understanding, capacity, great clarity about how they have made the decision. And before you withdraw the treatment, it's critically important that they understand what will occur when treatment is withdrawn, and even more importantly, that they understand that other means of supportive care are provided when treatment is withdrawn. So it's not the sense of I'm just going to withdraw treatment and there's nothing more I can do for you, but actually I'm going to stop this treatment because it's actually causing more harm potentially, or more of a burdensome effect on you than a beneficial effect. But in its place, I'm going to assist you with this, because as I withdraw treatment, you might start to feel a little bit more nauseated, you might get a little bit weaker, you might need more care, and these are the things we're going to put in place to facilitate that. So the issue of withholding treatment is more complex in this day and age, where we are dealing with great advancements in medical and clinical opportunities that are available for patient care, and also a more informed population of people who do their own research or who know what's potentially available and who come to you seeking particular treatments. Or when a variety of different options are available to somebody who might have an advanced illness. And in this instance, you once again need to return to the ethical principle of proportionality and burdensome versus non-burdensome treatment, and also understand that morally and ethically, as a clinician or a practitioner, you are able to make the decision to withhold treatment, even though a patient might be demanding a form of treatment. So an example might be a complex operation that a patient might want. For example, a cancer patient might have very advanced disease and might be looking for particular chemotherapies or complex operations. And in your best judgment and your knowledge, you would know that actually initiating these treatments or proceeding with these treatments may potentially cause the patient great harm. And you are not morally or ethically obliged then to offer these things to people if they seek it, but you are morally and ethically obliged to provide them with alternative means to manage whatever issue or symptom they may have. So one of the questions we are asked is, if we don't proceed with treatment, or if we're not proactive in actively managing somebody as they're approaching the end of their life, are we killing them? Or are we simply letting them die? And what is the difference? And one of the paramount issues to consider is the issue of intent. So the act of killing somebody occurs with the actual intent of ending their lives, either directly or indirectly. Letting somebody die is the recognition that somebody has an advanced illness and is progressing through a natural course of events, and that you are making good, clear-cut clinical judgments with discourse, with the patient if it's appropriate, with the family, to allow something that's inevitable to occur. So preparation for death is very important, and the mistake people make is that they start preparation for death as death commences. And actually we all have a life-limiting illness, it's called life. But when you're diagnosed with something that you know is going to lead to a poor outcome, or you're reaching a particular stage in your life where you know death is going to be inevitable, the preparation for death really occurs there. And the preparation has many components to it. So you can talk about the disease-related issues or the clinical-related issues, where you might want to have conversations about the kind of treatment you want to continue to have or not have, the options that are available to you in terms of where you're cared for, how you're cared for, and who cares for you. So that might be some of the clinical domains and how you prepare. There's also the spiritual domains of how you prepare for death. And for many patients, people make the assumptions that if you're non-religious, you don't have spiritual or existential needs, and that's incorrect. And it's important to work within an interdisciplinary group that facilitates these conversations, that allows people to be able to talk about or to vocalize some of their fears. And they commonly might be things like, I'm not sure what's ahead of me, or I'm not sure what's going to happen after I die when I'm not a believer, or I'm regretful for some of the things I have in the past and I'm not sure how to make amends, or I'm not sure where to put that part of me in this space. I'm not sure how to deal with it, or So providing conversation for dialogue, support, sometimes even some form of therapy for patients as they're preparing spiritually, existentially. And in the Catholic context, we talk about sacramental preparations, that people are able to get the sacrament of the sick, that if they want communion, that they can avail of it. And it's also important in other religious contexts, if you're Jewish or you're Buddhist or you're Hindu, that those of us who are caring for people at the end of life understand the cultural and religious requirements, and also not to make assumptions. Many people might have religious beliefs, but the cultural aspects of their beliefs might override the religious aspects, and vice versa. People might be non-practicing, but still might want specific religious protocols or procedures adhered to. There is also the preparation for the patient and the family as to what happens as you start to die. So that's a question that I'm commonly asked for by the patient. They would ask me, will I be in pain? What's going to happen to me over the next few days or the next few weeks? Families might want to have a little bit more detail. And there's some very good information available from Palliative Care Australia and Palliative Care Victoria about the process of dying, about the symptoms and signs that you actually witness as people start to die. And things like, you might take to the bed more, you will become more sleepy, you will eat and drink less, and that's a natural part of the dying process. You might not be able to communicate as much to your families. You might find that as you start to actively die, we say to the families that will be changes in the temperature, in the pulse, in the color, in the breathing. And we forget we are now living in a society where many people have never actually witnessed death. And I'm not just talking about the layperson. Many clinicians, the young doctors and nurses that I teach, have never actually witnessed the process of dying. So they proceed through many years of nursing or medicine, learning about many acute components of care, but they're never actually taken to the bedside of the patient to recognize that somebody is dying and what occurs as death occurs. So teaching them the physical sides, explaining to families. That's another form of preparation. There's also the preparation of legacy leaving and the legal aspects. So have you completed a will? Have you appointed somebody as your medical enduring power of attorney? Have you thought about letters that you might want to write or songs that you might want to live? If you work with creative arts therapists, music therapists or art therapists, legacy leaving can be a very beautiful and powerful way of leaving a card for your grandchildren, writing a piece of music for somebody that you cared for deeply. There's also the preparation of funerals. It can be very powerful if people know that they're going to die, that they articulate the kind of funerals they want to have. I have patients who have picked psalms or readings, who've picked the funeral music. Some people don't want to do that, but families need to prepare. Families also need to be told that it's actually okay not to do it now. If you're not ready, it's all right. It's okay to park it and that we deal with it after the event, because sometimes death occurs suddenly or very rapidly and people just don't have the emotional or cognitive space to deal with all of this. So working with a skilled team of clinical clinicians, social workers, pastoral care practitioners, allied health workers, creative arts therapists allows you to engage in preparing for death in a whole variety of different ways. So one of the things we speak about in the Catholic context is about the concept of the sanctity of life. And it's very difficult for people to sometimes come to understand it or grasp it, particularly maybe if you don't have a religious persuasion, but it can be very visible and real in the real-world clinical context. And to me as a palliative care physician, it's particularly poignant when you're at somebody's deathbed. Many years ago as a young trainee, I did a research piece of work on the moment of death, working in the west of Ireland, where with a very senior palliative care practitioner, we went and we interviewed people very quickly after death. Within 24 or 48 hours, we interviewed families. And the thing that really struck us was people's experience of the actual moment of death. And I really appreciate it now as a clinician at the bedside, when you actually witness that last breath, when life gives way to death, and that in that instant and in that moment, everything changes. Because even though somebody might be actively dying, completely unresponsive, breathing intermittently with a weak pulse, they are still completely there in their intact human being, human person. Life is still present. When the last breath is drawn in the cardiorespiratory, in clinical terms we talk about cardiorespiratory failure, when that occurs, everything changes in that instant, in that moment. And you become, in crude language, you can say you become a corpse. And everything for that family changes because that person is no longer present. And it's very important for people to understand that, because if people want to be present, that is a very powerful time of being. It's a time where, you might want to light a candle, or you might want to say a prayer. And for people then to sit in that presence after death has occurred and to actually appreciate the enormity of what occurs. Because once the body is removed, the complete physical presence of that person is absent. And your life changes completely. That person is no longer physically present in your being, in your living. And to me, the sanctity of life is truly visible when we watch life enter the world and when we watch life leave the world. And we now accompany people as they enter the world in every way and form. We video them, we draw up birth plans, we celebrate it. And in the same way, we must accompany people as they leave the world. Many people who work in the clinical space have never actually been taught about what to do or how to behave when people are dying. So a good example is when I work with young doctors and young nurses. And we do a ward round, or we go around and we see people, and they don't know what to do. So they might just stand at the end of the bed, and they might look and they might say, look at the drug chart. But actually it's really important, even though people are in the dying phase, that you have physical contact and converse with them, and that families see that you are still actively attentive to them. So addressing them by their name. Good morning, Richard, or good morning, Mr. Jones. It's Dr. Michael here. It's good to see you. Touching them, physically making physical contact with them. Feeling them. So simple things like touching their hands, feeling their pulse can give you a lot of information about prognosis, about how much time that they might have left. Do they have a steady, weak pulse, or do they still have a strong and regular pulse? Is their body starting to shut down? Are they cool to touch, or are they still warm to touch? Pull over the sheets and have a look at their legs. Have a look at their skin. Engage families. Tell families not to be afraid of touching or rubbing or consoling. I engage families by simply telling them to maybe massage or put cream, or the contact of actually rubbing some cream into somebody's legs. Mouth care is so critically important. People say to me, can you put up a drip? I don't want my loved one to die of dehydration. But the end of life, the more important and distressing symptom is actually a dry mouth. And all of the hydration in the world is not going to alleviate a dry mouth. It's actually oral care, using a sponge or a swab, and we teach families to do that. Dipping a sponge or a swab into some ice water or 7-Up, which can be refreshing, or a bit of lemonade, and using Vaseline on the lips, and families feel they're actually doing something, they're engaging in the care. Allowing them to actually assist in the washing and the turning, in the clothing, and they want to partake of it, they don't know how to do it. Making young doctors and nurses feel that it's all right to talk to somebody that's not responding back to you. To say, I'm just going to feel your pulse, I'm just going to listen to your chest. So these are the acts that show that we are a healing profession and that we are a caring profession. I would like to see more young doctors and nurses or clinicians have the opportunity to get bedside teaching about recognizing dying. What do you do at the end of life? Another thing that young clinicians say to me is, I don't know what to do or say when I'm asked to certify a death person. So I'm a young clinician at 3 o'clock in the morning, or a nurse, and somebody has died, and I've just come on the shift, and I've never met the family. And what do I say? Do I get them to sit in the room, or do I get them to leave the room? So teaching them simple things to, actually all people want to see is that you are compassionate and you care. That you read through the notes and you come up to somebody, you introduce themselves and you say, I'm just here to talk you through what happens with your loved one now that death has occurred, or I'm just here to go through the process of certifying death. Acknowledge their loss. I have never met your father or I've never met your husband, but I've been told by the nursing staff that this was occurred. I'm sorry that it has occurred. Engage in some simple conversations. Were you present as they died? Are there any questions that you might have? Offer them the opportunity to either stay or leave as you go through the process of certification of preparation of the body. Some families want to be present. Muslim families don't want to leave the body at times. Some Jewish customs recommend that somebody is always present. So allow people for those opportunities. Yeah? Treat the body with respect and dignity. Ensure that, I think there's something to be said about ensuring that people know that death has occurred. In caged care facilities and in our hospice, we're having a conversation that do we leave a light on in a central place where there can be a collective acknowledgement that death has occurred. People get to know each other in these units, that grief is allowed to occur.